Thank you everyone for joining us. Good evening. My name is Sarah Bloom. I'm the Director of Family Services at Lifeline Canada. And we're very excited tonight for our panel talk on fertility after treatment. I would like to introduce Rachel Tuchman to you. She is going to be the moderator for the evening. And Rachel is a licensed mental health counselor who has worked with individuals going through difficult life circumstances, including women experiencing infertility. Currently, she offers services in her Cedarhurst, New York office for kids and teens ages 5 to 18, adults and women experiencing infertility, pregnancy loss, and post-hysterectomy. So Rachel, I will turn this over to you. Thank you.
Hey, thank you. I'm really honored and excited to be moderating this discussion tonight. I just want to start with a disclaimer that tonight's discussion is for educational and informational purposes only. It should not be construed as personal medical advice for anybody on here. All topics are going to be covered just generally and are intended just to be springboards for further learning and discussion. I want to introduce our panel tonight, and then we'll get started. Dr. Aimee Barron is the founder and executive director of I Was Supposed to Have a Baby. Dr. Barron was formerly the director of innovation and growth at Nechama Comfort and has also worked as an attending pediatrician at the newborn nursery and neonatal intensive care unit at St. Luke's Roosevelt Hospital before taking a leave of absence after her third miscarriage. Aimee lives in the greater New York area with her husband and children, somehow managing to find time to whip up gourmet eats in between Instagram posts. And her babka pictures are always delicious, I must say. Dr. Batsheva Lerner Maslow is a reproductive endocrinology and infertility specialist. She attended Albert Einstein College of Medicine, earning a medical degree with distinction in reproductive endocrinology. Wow. Dr. Maslow completed residency training in obstetrics and gynecology at the University of Pennsylvania and her subspecialty training in reproductive endocrinology and infertility at the University of Connecticut. She also completed a master's program in clinical and translational research at the University of Connecticut, focusing on both medical research and the communication and application of scientific findings. Prior to joining Extend, Dr. Maslow was an associate physician at a top-ranked private infertility practice, Gold Coast IVF in Long Island. Her research has been published in Obstetrics and Gynecology, Fertility and Sterility, the Journal of Assisted Reproduction and Genetics, and other key medical journals. Additionally, Dr. Maslow writes and lectures on topics related to the intersection of Jewish law and reproductive. She serves as the director of the Medical Education for Nishmat's North American Yoatzot Halacha Fellowship Program, which trains female scholars to address questions in Jewish law related to women's health. She's also a wonderful writer and a very sensitive and skilled practitioner. I know from accounts that I hear from people who go to her and just from my experience with her and seeing all of her wonderful content on her social media page. And Rabbi Weitzman is the director of PUA Institute in the US and the head of the English-speaking section of the PUA Institute for Fertility and Medicine in accordance with halacha in Israel. He was born in Britain and studied in Yeshiva Beit El, receiving rabbinic ordination from the Israeli chief rabbinate. Rabbi Weitzman is a visiting associate principal in the Albert Einstein College of Medicine in New York, and he teaches in the Gros Kollel and the Midrashah for women. He has a private clinic to treat issues of intimacy within a halachic framework. He has published numerous articles on a variety of topics. He's a regular contributor to annual halachic compendium Tuchman. In addition, he has published 3 books on the philosophy of Rav Kook. He has spoken at many major rabbinic organizations, as well as many academic forums, such as the annual meeting of the American Society for Reproductive Medicine, Columbia Medical Center, and Cornell Medical Center, where he has shown a synthesis between medicine and halacha. Rabbi Weitzman is a popular speaker and discusses a wide range of topics. You can listen to his shiurim on YU Torah and Torah Anytime. So we have a wonderful panel of very skilled and educated and knowledgeable individuals tonight. And I'm going to hand over our introduction to Dr. Maslow to just give us a little bit of information on data and fertility options and kind of start our discussion.
Thank you, Rachel. Thank you for that introduction. And thank you to all of the organizers to this event. This is a wonderful opportunity for us to really start an important conversation. And I frame it that way as it really is a start to a conversation. There's a lot here to talk about. We have a lot that we want to cover. And I don't think we could ever give this topic justice in just one event. And part of that is because it's extraordinarily individualized, both not only from a medical standpoint, each individual diagnosis, the age at which that diagnosis was given, what treatment options were given at the time, and then also the experience in survivorship is going to be very unique to each individual person, their health, their experience. And so, like Rachel said, we're going to kind of talk in broad strokes, and hopefully this is an opportunity for people to really think about what some of those experiences are, what kind of questions we can ask, and what options are available to look into the future. So I'm going to start off by saying, on the one hand, chemotherapy and cancer treatments in childhood are known to impact the fertility and the reproductive health of survivors in young adulthood and then through adulthood. How much they impact is extraordinarily variable. And a lot of it depends on individuals, how that person responded to their chemotherapy, how their reproductive system responded to the chemotherapy or treatment. It certainly depends on the treatment that was given, and a lot of it depends on the age at which the treatment was given. And so there isn't some kind of broad stroke answer that I could give about how is fertility affected by pediatric cancers, other than to say that it generally can be, but it doesn't have to be either. And so that variation can go from having a very significant extreme impact to having almost no impact. And it's really hard to know just from the surface. And so part of what I'm hoping that we'll get out of this evening is to really understand what kind of questions can be asked. You have a young child who underwent treatment in pre-puberty, 3, 4, 5, 6-year-old child. What happens to that child as that child develops? Does the child go through puberty on their own? Did they need assistance, medical assistance, endocrine assistance going through puberty? And then at what point is it appropriate to start asking questions as they get older, both from a psychological, emotional standpoint and from a medical standpoint? I'll tell you, some of this is going to diverge between whether we're talking about a female or a male. So for women, women are born with all the eggs we'll ever have. There's a huge supply when we're young, and over time, that supply will naturally decline. Often, cancer treatments can cause a huge sort of chunk to be removed from that supply. And how much and how long and what's left are all questions that should be asked. And sometimes it's good to intervene and good to ask those questions early, because a 20-year-old is going to, by definition, have a much greater supply and many more options and more flexibility than a 35-year-old might. And so being able to ask those questions early actually gives the opportunity for more options and more interventions that might be able to help those who have survived pediatric malignancies to reach those reproductive goals and family building goals that we all have, and to achieve them. For boys, it could be different. For boys, there's very much sort of all or nothing. If the fertility survives the chemotherapy treatment or the cancer treatment, often that's, they don't have to worry about what's going to happen as they get older. If it's there, it usually, for the most part, will continue to be there. The question is, when is the right time to check that? How do we check it? That obviously also brings in all sorts of halachic questions as well, that I won't get into, but suffice it to say that we shouldn't really make assumptions about what happens to our children's fertility. We shouldn't assume that the fertility is going to be perfect, but we also shouldn't assume that it's definitely harmed. And some of these questions can be investigated with testing that can be done in early adolescence or early adulthood, even blood tests and ultrasounds and relatively non-invasive testing that can give an idea of what kind of picture are we looking at, what kind of opportunities might there be. And I'll just end with one sort of brief kind of example of how I've helped patients of mine in kind of address these questions. So I have a pretty large group of patients who come to see me for egg freezing. So I've become kind of a go-to person for single women to come to talk about fertility preservation. I have a fair number of patients who are in their 20s, young, many of them Orthodox, but not necessarily, but young single women in their 20s, some of whom had cancer treatment in their either early teens, 12, 13, 14, 15, 16. And at the time, we're not given the option to think about fertility preservation. This is something that's really common. We're now we're offering fertility preservation more to young adolescents, but 5, 6, 7, 8 years ago, that really wasn't the case. And so it's pretty common that you have these young women who had treatment in adolescence. Many of them, when we look at their ovarian supply, and this is supported by the data, they're going to have a lower ovarian reserve, a lower amount of eggs than the typical person, let's say the typical 25-year-old might. But here's their opportunity to actually do some fertility preservation well after their treatment. So they can freeze eggs. Maybe sometimes it will take more cycles than it would if they were 25, but they could put eggs aside so that should they experience infertility in the future, and we do know they might be at risk for that, here they've been able to kind of give themselves a backup. The same way that I have older single women who are doing that just for the effects of age, here are women who we know might have a more profound impact of age, who are taking steps to be proactive. And that's an opportunity that they get because they ask those questions. And if they're in early adulthood, if you don't ask those questions, it's really hard to know that those options are available. So that's really my primary goal for today, is to help us. We'll talk about a bunch of different potential options, but really not to rule anything out, and to ask questions and be curious and be proactive really allows for children who have survived these hardships in childhood and adolescence go on to hopefully have normal, productive lives where they also, that includes having a family.
Thank you. And I think that, I mean, we'll get into this a little bit more, but I think that it's so, like, being informed yourself as a parent or as a family member is so important, because if you have a child who's going to have to go through these treatments, it's so important to keep those talks ongoing with your child so that you can plan for treatment and what comes afterwards. And then they'll kind of have an idea, like, we're not alone, we have options. It doesn't have to feel scary, even though right now it does. There's a lot that's unknown. I think it's important that we have those conversations, and also keeping hopes realistic, right? Like, you don't want to be like, the doctor said everything's going to be fine. Or maybe you have a very negative doctor who says, like, oh, it's not looking good. And we just kind of want to keep the balance of, like, we know that there's a possibility that it might be difficult, but, like, we're going to do everything we can, and we're going to look into options. And I think that's why it's so important to, like you said, ask your doctor early on. Don't wait till it's, someone's 20, 30 years old and start looking into things. And you have support, get that support. It's available to you. And I think things like this, right? Conversations like these are very important also, because it is a way for you to kind of know what's out there and know what's available and explore it more. I want to share Rabbi Weitzman's video.
The subject this evening is a very difficult one. The subject of treatment after fertility after treatment, treatment which may lead to a problem with fertility. And I wanted to think about before the treatment and after the treatment. Something that's very, very essential to think about, and I hope that many of the other panelists have mentioned it, is the supreme importance of providing fertility preservation for young men or women who are undergoing fertility, who are undergoing treatment for cancer, treatment for that may include radiation, chemotherapy, and others. It's almost impossible to put too much stress on the importance that this has in ensuring that their fertility will not be compromised and won't be later potentially even diminished completely. It's true that many treatments will not in fact impact fertility, or will not adversely affect fertility, and many men and women who've undergone treatment will end up being fertile. That's 100% true, and I'm sure that the panelists have mentioned that and have spoken about that, how important that is to remember that not every time we go through treatment we will definitely impact fertility. We're having this week in Yerushalayim a wedding of a young man who, at a very early age, had cancer, and Baruch Hashem, got better, and he's getting married, and for all the testing that we've done, he seems to have absolutely no impact on his fertility. However, That is not always the case. And the importance of preserving fertility, which means preserving eggs or sperm when they're available, or even testicular tissue or ovarian tissue when that is the option. And in order to know that option, we'd have to talk with the oncologist and the gynecologist and the urologist, the reproductive endocrinologist, to find out what is it that can be done. The importance of that is twofold. First of all, we are ensuring that person will maybe later be able to be a parent. And that in itself is very, very important. Although we asked poskim that question, is a man allowed to produce a sperm sample? A young man who's undergoing cancer treatment, are they allowed to produce a sperm sample? At the moment, the guy is 12, 13, 14. He's not married. Is he able to produce a sample? Would that be a question of really he's not doing it in the framework of procreation approval? There was one posek who thought that was a problem, but almost all the other poskim disagreed with this, with particular Rav, and said that not only is this permitted, maybe even they thought it was even a chova, it was even an obligation. And the reason why it's an obligation is very, very important to understand the psychology. I have had very many conversations with men and women, their parents, of people who are undergoing treatment, undergoing cancer treatment, undergoing radiation with chemotherapy and other treatments, and we talk about fertility preservation, and at the end of the day, all they care about at the moment is getting their child better, and that's the child to be healthy, and that's of course of supreme importance. But when you start saying we talk about fertility preservation, what am I really saying? I'm saying your child is going to get better, and they want to be a parent, they want to be a mother or a father later on in their life, and we are giving them this opportunity. And when we did that, and when we couch it in those terms, what we're really saying is that fertility preservation is part of the treatment of giving that person hope that they will live long life and they will want to be a parent. And I'm giving them that whole perspective, which often changes the perspective of the parents, of the patient themselves, believing I'm going to get through this and I'm going to be an Abba, I'm going to be an Ima. And that idea is so powerful that many of the poskim thought that would contravene the possible potential halachic question of producing a sperm sample. For women, it's obviously less of a problem because we're talking generally about the ability. There's no question of masturbation or wasting seed for a woman, but for a man, that potential question of wasting seed, of unnecessary ejaculation, was contravened by the importance of this as part of their refuah, part of their treatment, and that's a very important thing to remember. There are, of course, halachic questions related to how do we produce a sperm sample? At what point can we do that? There are several methods. There's testicular biopsy. There's an indirect method of electroejaculation, and there's more direct methods of stimulation to the genitals with some sort of vibrator that we've worked with, or even actual masturbation. And those are questions that need to be individually discussed with the posek. For this particular case, what would be appropriate? Which method would be appropriate? It's also essential to have a discussion with all of the medical staff, because the oncologist, their job is to get the child better. They are really focused on that, and they're sometimes less now, but in the past this was definitely the case, that oncologists were so focused on that task that they forgot to even think about fertility preservation. It's important to have a discussion with the reproductive endocrinologist, with the gynecologist, with the urologist, with the whole staff, with a psychologist, with the rabbi, to be able to create a staff, a team that we are together going to support this treatment being done, and to make sure that we have the potential of fertility preservation. Now remember that in certain cases this will mean pushing off the treatment, pushing off the cancer treatment for a certain amount of time. Again, we need the oncologist to be on board. How can we do that? Can we do a minimal treatment? Can we push off the treatment? And those are things that we deal with every single day in Puah here in Jerusalem, but also that we deal with around the world. And those are things that need to have to be initiated. And if we don't think about them, we need to sometimes initiate that conversation. We, the rabbi, we, the parent, we, the medical professional, we need to be able to initiate that conversation and say, let's think about fertility preservation. Is it at all relevant? Is it at all available? Is it an option in this case? That's a very important thing to think about. We, of course, used to a question about using that later on. We have frozen sperm, we have frozen eggs, we have frozen testicular tissue, frozen cryopreserved ovarian tissue. How can we use it? Of course, this is a developing technology. And so some of the things that we do today, we may be not doing in 10 years' time when this child comes to have children. And so it's important to be up to date and to have a medical staff that are up to date as to how it can be used. And of course, how they can be done medically. And within that, it's also very, very important to stress the importance of having halachic supervision. When we freeze eggs or we freeze sperm or testicular tissue or ovarian tissue, it must be done under halachic supervision. And that means that somebody from PUA is present to ensure that there's no question of a mistake being made in the lab, which would later on have ramifications for the legitimacy and the lineage and the authenticity of the lineage of this particular child that may be born. And so it's important to order supervision. It can be done through PUA. You have PUA contact in your literature, and you can get it from our website, from PUA online. And you can get it from also from Small Wonders, of course, also have a constant connection with us to supply supervision to ensure that there isn't a question. And that's important to think about fertility preservation. Baruch Hashem, our young person, not so young person, went through treatment, got better, Baruch Hashem, and they're coming to think about starting a family. It's important to do testing to ensure that there is a potential for fertility. So we would do for a woman, we would have hormonal tests, we would maybe a gynecological examination to ensure that there is ovarian activity, that maybe we can see that there's actually not a question of fertility been impacted. There maybe is not. We don't need to use those eggs. We don't need to use those ovarian slivers, and that's something too important to have an ongoing assessment as the fertility potential of that person. And for a man, it's a slightly more complex issue. And that question: do we permit to do a semen analysis for an unmarried man in order to allow him to get married? And the answer to that is it's very difficult to give an answer. Each case is individual. Each case is individual because each case is different as to the medical reality, but also the psychological reality. And I want to give a word about that without giving a psak in each case to understand what we're talking about. There are cases of men who, in fact, to do a semen analysis would be devastating for them. Because if they find out that they really have an impaired fertility, not only did they have cancer, but then they have impaired fertility. They can't live with that reality. For some men, the exact opposite is the case. They already are living with this guilt or this fear that they have fertility, a diminished fertility, and now to take that and to add on to that they also have this question whether I'm going to be able to get married. It's for them too much pressure. Sometimes for them, the answer would be that to do a semen analysis, in fact, would be changing their entire lot and allowing them, permitting them to get married. And so it's very important to look at that individually and then to have the conversation with the posek as to how can we produce a sample. As we said before, there are different ways of producing a sample, through indirect method called grama, or through electroejaculation, or even through masturbation. Those are questions that we would need to raise in each individual case. What would be the potential, the possibility of testing, and how can be done in a halachic framework? And so that's important before we even embark on getting married. There's another question, a question that was asked in the questions that people submitted, and I think it's essential to think about, which is, how do we share that information? When we share information before shidduchim, we have two different factors that need to be considered. One is the privacy and the dignity of the person coming to get married, who's undergone treatment, who's undergone cancer treatment. And not only did they have cancer treatment, now we're going to tell them also you have to release it, tell all the information. Every string of your medical file has to be opened. Everybody wants to see it. We have to preserve their dignity, their tzniut, and their privacy, that we don't have to look into every single aspect of their life. And that we call lashon hara. We don't have to share information about other people. That's one. On the other hand, there's another factor that's very, very important to think about, and that's what we call mekach ta'ut. Mekach ta'ut means that I purchased something, and I thought it was item A, and it ended up being item B. I bought a suit. I thought that the suit was a particular make. It was an expensive make, and it ended up being a much cheaper brand. And in fact, the person who sold me the suit had put in an expensive label, and in fact, it was a cheaper suit. That's a mekach ta'ut. I thought I was buying A, and I ended up buying B. Even though getting married is not buying, there's still almost a contract. I entered into a contract thinking that my wife was one thing, and it ended up being something else. I thought that she was healthy, and all of the things that I asked before, everybody else said she's healthy, and when I actually came to be married, I find out she isn't healthy. I find out she has diminished fertility. And so not only do we be concerned for lashon hara, we're also concerned for mekach ta'ut. We're also concerned for misleading, and often even more than misleading, actually actively lying about someone's situation. Those are very complex issues, which again, we can't answer in this few minutes that I want to share with you. But we have to think about to get very specific guidance. And the guidance would be dependent on the actual situation. What did happen? How have we assessed so far? What age was the person? Do they have fertility? Do they have frozen eggs, frozen sperm? Have they undergone subsequent testing? And so there's a lot of information that is important that we think about before we even suggest when that should be shared, or how it should be shared, or if it should be shared. What is the other side? What is the other side bringing to the table? Maybe they also have an issue. Maybe there's also something that they're not sharing, and that's something that we also need to encourage them. The best is for them to share it themselves, not for an outside person to tell that and to share that. When do we share it? Do we share some things which are essential? If a person completely lost their fertility and is now completely infertile, and there's no possibility they're going to have children without having very complex issues, which we'll speak about in a moment, then that's something that we can't wait and share that later. That's something that's essential. A person would want that. We imagine that people getting married, at least at a youngish age, would want to have children, and therefore the inability to have children is so essential that we can't not share that information. But if there's a question, if there is a suffix, if we have frozen eggs, and the person we would be perfectly happy to use that as a way to have children, and there's a certain emotional connection between the young man and the young woman, then the sharing of information will be different, and maybe will be shared later on in the relationship, not right at the beginning. And so it's essential before we decide what are we sharing, how are we sharing, who's going to give that information, to know what exactly it is, the situation, and what it is we're about to share. That's very, very important. And so we can't give it a specific answer in each case in this forum, but we should know those are the two things that we're thinking about. Lashon hara against mekach ta'ut, against lying. And unfortunately, I've been involved in cases in which there was a problem of lashon hara, and I've also been involved in cases in which there was a problem of dishonesty, of couples, of parents not sharing information, not with their own child who went through the treatment, and not with the potential spouse or the potential spouse's family. I want to go a little bit further because there was another question that was asked. Let's imagine that a person doesn't have fertility, the potential after having treatment. They have no eggs, they have no sperm, they have no spermatogenesis, no oogenesis. What then is possible to do? We get in there into, as we said before, we mentioned before, very complex halachic issues. The issue of using an egg donor is a halachically complex issue, which again we can't completely cover in this limited amount of time. But we should know that there is a machloket poskim, there are differences of opinion as to whether we can use an egg donor and to use a gestational carrier, to use a surrogate in the case in which we had a uterus removed. Those are halachic questions. And the question beyond that, beyond the permissibility of using, is also the question of how do we define parenthood, motherhood. Is the mother the woman who gives the egg, or is the mother the woman who carries the baby and delivers the baby and gives birth? And that will have ramifications as to whether we're talking about a case of an egg donor, who could be the donor, whether the child would need to be converted later on. That would be ramifications for the case of a gestational carrier, a surrogate, as to whether the surrogate could be married or has to be Jewish, or the child needs to be converted. These are complex issues, which again we can't cover in their entirety in this forum. But we need to think that these are complex issues. Who can carry them? Can it be a family member? Can it be a parent, mother caring for a child? These are complex issues. When we get into the question of sperm donor, so we have a young man who went through treatment who doesn't have spermatogenesis, then we would have a very complex issue of, can we use a sperm donor? There's a very famous tshuva of Rabbi Moshe Feinstein who permits using sperm donor, not in the case of, that we have here, but in other cases in which a man was born with an inability to produce sperm, not because he went through treatment. That's the way he was born. And Rabbi Moshe Feinstein permits it using a non-Jewish sperm donor. The reason to use a non-Jewish sperm donor, which seems to be counterintuitive to a lot of people who think we'd use only a Jewish sperm donor, is because if we have a Jewish sperm donor, we have a question of yuchsin. We have a question of the child being born is potentially related to any potential spouse. And so the question is, can they get married at all? Maybe every single woman that they come to go out with would be their sister. And so they wouldn't be able to be married at all. We have a non-Jew, we reduce that problem because the non-Jew doesn't have yuchsin, doesn't have that filial relationships, and therefore it would be easy. That doesn't mean that if we use non-Jewish sperm, we're allowed to do it in every single case. Again, these are complex issues which need to be looked at case by case, but that's a concept of what we have. And so we looked at, in the time that I presented to you, we looked at the question of fertility preservation using halachic supervision. We spoke about methods of producing sperm. We spoke about what do we share during shidduchim, how do we share it. We spoke about the use of the question of doing testing before getting married, and we spoke about the question of using third-party fertility treatment. It should be clear from this short presentation that these are complex issues, but Baruch Hashem, we have Gedolim, we have Poskim, we have an organization like PUA that is able to give very clear, concise, and relevant information and answers to be able to allow all of these young people who went through this terrible crisis, but Baruch Hashem survived, and Baruch Hashem are healthy and are now want to become parents, to enable them to become parents. If we have any specific questions, we at PUA are always happy to help, both in America and also here in Israel. And Bezrat Hashem, we should only have good news. And again, thank you very much to Small Wonders for everything they do, and also for inviting me to participate in this panel. Shalom, shalom.
That was I thought very comprehensive, very thorough. If you guys have any thoughts on what Rabbi Weitzman said, I would love to hear.
So hi, I'm Dr. Aimee Barron. I just wanted to introduce myself. I thought he did a really beautiful job at laying out the different possible issues that can go along with one who has a cancer diagnosis, and talking about fertility preservation and thoughts about dating and thoughts about shidduchim and thoughts about all of these pieces and what happens later. The piece that I thought was most important is exactly what Dr. Maslow was saying before. The idea about knowing what the diagnosis is, the idea about figuring out what the possibilities for preservation are, getting to those possibilities and doing those possibilities as often as possible and as much as possible throughout the time that your child is going through this, meaning if they, have a diagnosis when they're young and they're, 2, 3, 4, as opposed to, 13, 14, 15, but really staying up with the medical research and making sure that whatever options are available medically are also available for your child in terms of fertility preservation. I also thought that what he said, which was 1,000% correct, in that these assisted party reproduction methods, egg donation, sperm donation, surrogacy, are complicated halachic matters, but he did not say that they were not allowed. So I want that to be very clear. Both Dr. Maslow and myself have worked with numerous families who have had like lots of complicated halachic conversations with their post-kim in their communities. And these families do have children with egg donors, with sperm donors, and with surrogates. Whether the child gets, converted before or afterwards, whether it's, a non-Jewish surrogate, a Jewish surrogate, whether it's a Jewish egg donor, whether like all of those things are specific for your postseg to answer for you. But I don't want anyone to walk away from this talk thinking that those are not options, because they absolutely are.
Agreed. Yeah. And I think that, like you were saying, like the theme of each topic that he touched was like, you need to talk to someone and ask, and we shouldn't assume that something is off the table. And I think the same goes also just for medical treatments also. Don't assume that something is off the table or that you have to do something or you can't do something. He said, get that team together, speak to everyone involved and ask the questions. And that's the doctor, and that's the rabbi, and that's the therapist. And it's so important. And that kind of leads into our next topic, which is stigma, and how stigma can really prevent people from having these conversations, from feeling safe to ask the questions, from feeling like they're comfortable even asking the questions, from knowing that when you ask that question, chances are this rabbi, this doctor, this therapist, whoever has already heard this question before. So they're not going to look at you like you have a third eye. Like, this is what they do. And I think that when we have conversations like this and we break down stigma, and we're going to talk about stigma and the effects, like, we make it easier for people to access the care that they need and to get the support that they need. And unfortunately, there's stigma in the general world, but in the Jewish community, I find that we are always kind of like 10 steps behind, a topic that's kind of come out in like the secular world. We're always like lagging a little bit before we realize like, oh yeah, we have that problem too, and we've come a very long way. And I am so proud of the Jewish community, but I think that we need to continue having conversations like these, and we need to have organizations like PUA and High Lifeline who are reaching out and saying, hey, community, like, we're here and we know that there are these issues and like, we want to help. So I really just want to kind of define what stigma is, and then I'll hand it over to you, Aimee, to kind of share a little bit more on this. But stigma is basically when we're assigning like negative characteristics or traits to something that we think is like a disadvantage or a negative stereotype. So we see a lot of stigma around mental health. We see a lot of stigma around fertility. There's a lot of stigma around lots of things, but since tonight we're talking about this, we're going to keep the focus on this. But stigma in general is very negative because it can create shame, right? Which can just make problems even worse, right? We know that secrets only make things harder and more difficult. And if you're not talking about something, like Dr. Maslow said earlier, like, it's so important to get that help early on so that you're not stuck in a situation later. So if you're terrified to talk about something because you're afraid your kid is not going to get a shidduch, or because you think people are going to think that it's a failing on your part that your child has cancer or has, fertility issues, then we could be exacerbating an issue and creating issues that didn't even have to come to be, because we didn't talk about it. And hiding it can make us, again, put us in a worse position medically, but also emotionally. It can make us more depressed. It can make us angry, resentful, hating our Jewish community, hating the people around us, just needless suffering. And we need to make it safe for people to ask for help. So I think that when we reduce stigma, we help people better recognize what, these issues, and they're more equipped to know how to support community members. And we're going to talk about that in a little bit. We can help people obtain the best help and treatment, right? Because if we know the best providers, mental health, medical, rabbinic, people that we know deal with these specific issues, we can treat, we can head, spirit, kind of guide people to the right professionals. We can reduce discrimination and hostility towards people, which I think is very important. And we can also better enable caregivers and loved ones, right, to learn how to support people going through this. And that's very important, because I think sometimes people mean well when they're trying to support family. And again, we're going to talk about this a little bit more in our next part of this talk, but sometimes they do more harm. And so I think we need to just kind of talk a little bit more about stigma and I guess like how it can impact someone in this situation.
Absolutely. I think the most important thing, there are many takeaways from this talk, but from my perspective, the most important thing that you can take away, you as the individual who has had cancer, you as the family members, the parents who are, trying to just give over as much love as possible and protect your child as much as you can because you're their parent, and all of the family members and all of the people that are surrounding that child. I need you to know something. None of this is your fault. You did nothing to cause this. I talk about this in regard to fertility all of the time. I have conversations with people over and over again. Well, it was because I did this, or because I didn't do that, or because I ate this, or because I wore this, or because I said this, or because I wasn't, pious enough, or because I wasn't sneeze enough, or I could give you a list. Dr. Maslow actually just had a post the other day talking about all of the things of how we blame ourselves for things that we think are our fault. So I'm here to tell all of you, none of this is your fault. Cancer is a medical diagnosis, and fertility and infertility are also medical diagnoses. We know in the general population, people that have nothing to do with cancer, we know that somewhere between 1 in 6 and 1 in 8 couples are going through some sort of infertility. So really what that means is that if it's not happening to you and it's not happening to someone in your family, it's happening to someone that you love and someone that you know very, very well. We all know that person, and there is nothing they did that was wrong that caused this. So I just really wanted to lay that out there to begin with, because a lot of the questions that came in were, my daughter had cancer when she was young, and now we're not sure what to say or how to say it, or we don't think she knows or remembers, or my son doesn't know or remember. And so there's this overlaying, as Rachel was saying, this shame, this secrecy, this almost the fault, overlies all of it, the guilt. And so I want to try to take a little bit of that away, because if we can take some of that away, then a lot of these things become a lot easier. You didn't do anything to cause this to your child, right? So, and the more that you can just sort of let that go, the message of everything that we've been saying here tonight is that you will be able, without shame and without feeling bad about yourself or the questions or the kinds of things that you're asking, you can reach out for the help that you need to your Rav, to the medical doctors, to the reproductive endocrinologists, to the OBGYNs, to the urologists. You can do it without feeling any shame, and you can get the best treatment for your child. And that's really, at the end of the day, what you want. So I want to also equate this kind of situation with another situation that's very common that goes on in the fertility space. It's not only the people that have to go through fertility treatments just because they have a medical diagnosis of fertility, right? We think oh, she doesn't have any eggs, she doesn't have any sperm, or she has PCOS, or whatever it is, they have unexplained infertility. So therefore they need to go through fertility treatments. You, in your families and in your situations, you might need fertility treatments, keyword again, might, because of something beyond your control. Again, not your fault. But you're not the only ones in this situation. There are others who have other genetic disorders, Gaucher's, Tay-Sachs, 1,000 other genetic disorders, or maybe they have what's called genetic, they have chromosomal translocations, they have some sort of issue with this specific chromosome where they too also would need to go through IVF, not because they're infertile. So they also feel this shame and this stigma, and it has nothing to do with them, and it's not their fault. It's also just a medical diagnosis. So I just wanted to bring that point home to try to dial down the temperature here and help everybody feel a little bit better in whatever way we can about this whole situation. So one of the things that we keep talking about, and the questions kept coming up, are also about this, when should we tell our child? When should we have the discussion? So I think that needs to be broken down into two different categories. There are the kids who do know. They know they've been through cancer treatments. They know something has happened, but they don't know what it means. And you know that they know, and they know that you know, but nobody's talking about it. And so that can create lots of anxiety, lots of, self-identity, self-image, lots of issues, especially in the teenage years. And as they're thinking about dating and shidduchim, can I have kids? Can I not have kids? It is for a child who knows already that they've been through something. The best thing to do is get it all out in the open, to have the discussion with them, to bring them into the doctor appointments, to have them understand exactly what's going on so that they can feel like they have some piece of control in all of this, in something that just happened to them. So when they know, it's much better to have that conversation earlier and keep them abreast of what's happening and the things that they need to do so they can feel more in control of their life. For other children, and some of the questions came in like this, my child, went through cancer treatments when they were much, much younger, 2, 3, 4, whatever it is. And now they're older and I don't know what's going on. There might be something, but I need to tell them. And then what does that mean? And then is that going to ruin their chances? And who's going to want to date them? And how do I bring them into this? Maybe it's just better if I don't say anything. Look, as Rabbi Weitzman was saying, there's the Lashon Hara, and then there's the lying. So I don't think that any of us want to be in any of those camps. I think the middle road is the truth. And for every family, you have to decide, along with your posek and along with the people that you trust in your life, maybe in counsel with a therapist or a family therapist. Maybe your doctors have different therapists that they work with to have these kinds of discussions. But the suggestion always is when you think the child is mature enough to understand the information, but not too mature that they're already spinning and thinking, oh, they can date anyone and everything is going to be fine. There's that window of time where it's appropriate to share. And I'll even go so far as to say that the earlier that you do that, the better, because we also have to think about teenagers and identity crises and them thinking that their lives are fine and perfect, and all of a sudden being hit with this bomb of my life is not what I thought it was, and how could you be hiding this from me all my life, so to speak. So I personally, in consultation with lots of people that I've had conversations with about this over the years, I'm personally of the opinion that the earlier that you can share this with your children, the better. Appropriate for their chronological and their maturity. But the earlier you share it, the better, because teenagers in general, as I said, are going to have these identity crises and will to have to grapple with all the regular things they're dealing with, in addition to now hearing, oh, I don't know if I can have a family, is very, very hard. And as you're telling your teenagers, whether they do know, whether they don't know, I always recommend making sure that they have psychological support all the way through. They are going to need a safe space to talk about this to someone that's not in their family, a safe space to break down, a safe space to just let it all out, to cry, to scream, it's not fair, all of that. They need a safe space to do this.
Thank you. I think that part of what you were saying also kind of goes back to like the way that we break stigma is by normalizing conversations. And that means when it starts when our kids are young, right? When we talk to them about things like, this is just, you know, this is what's happening for you and there's no shame and this is the reality and it happens to a lot of people. That's how we kind of carry over to the next generation, that lack of shame, that normalizing that, yes, these things happen to people and like, you're not some, you know, freak of nature and an outcast or a weirdo. And I think that that's really, something that we need to think about too. And I think sometimes parents are hesitant because they think like it's scary and I don't want to scare my child. But the reality is that like secrets are scarier. And as much as we think like our kids don't know or they're not going to pick up, they hear conversations, they might, you know, see something that was, you know, in your phone or in your email, or they might, you know, hear you discussing an appointment, or someone might ask something in front of them. So it's really like honesty is really always the best policy. And like you were saying, we can give it in like little pieces, little chunks. It doesn't have to be everything at once. It shouldn't be everything at once. It should be kind of like things that are built upon, and letting them know at developmentally appropriate points and stages, like information that's relevant to them. Because like you said, you know, it could be that when they hit puberty, if things aren't happening the way that they think they are supposed to be happening, because they're looking at their peers and they're like, hey, what about me? And you didn't prepare them that this might be the case for them, that it might happen differently for them, there will be a lot of resentment and anger and feeling like you betrayed them. And that's definitely not something we want. You know, as parents, you want to be the protector and you want to be that safe space and you want to be the person that they go to, you know, for all things. And so the way that we do that is we're always very open and honest and upfront. So I think
I'll just add, yeah, I'm just going to add one more piece. There's a lot of research that says that for parents who have children that were born via surrogate or sperm donor or egg donor, the research is all showing that the earlier you tell your child, the better. When they grow up with this narrative that this is the way they came to be, it's something that becomes part of their narrative, and it becomes part of their existence. And does it become this shock piece that then they have to accumulate later on when you decide that maybe it's appropriate to tell them? Obviously, every family, every community, everybody does things differently, but there is a very large body of research out there right now in the last number of years that really has been pushing this information as young as possible, developmentally appropriate, to bring children up with the notion that they needed help, and that's okay.
Yeah. I'll add from the medical perspective, you know, I think socially, especially from communities, we sometimes we weave this notion of like, there's a normal person, that somebody's normal, or family is normal. And that creates this otherness, that creates this feeling of, if I don't fit a particular mold, or my child doesn't fit this particular mold, that there's something wrong with me. Now, as a physician, particularly a fertility physician that sees lots and lots of frum couples, I see couples in their most vulnerable points. And these are couples who were perfect shidduchim, top shidduch, who now all of a sudden have a fertility issue that no one would have prepared them for and no one would have predicted, right? And there's this notion that if everything went perfectly, that everything should continue to go perfectly. And the reality is that we all have issues, or every family has issues. Something comes up in every family. We're going to hit challenges, whether that challenge is a child who's ill, a fertility challenge, an older challenge with an elderly parent or an elderly family. We all have our challenges. And knowing that other people are going through it doesn't necessarily make those challenges easier or more surmountable, but it allows us to feel a part of the community as opposed to outside the community. And, you know, to dovetail on what we've been saying about kind of bringing children up with this narrative and this legacy, particularly when I see adults who have survived pediatric cancers or adolescent cancers who are coming to me for fertility help, there's Sometimes there's a pride in that. That's, this happened to me as a child. This was a challenge. It was a really tough childhood, but I survived, and I survived with the incredible, miraculous help of the medical community. And there's something to be proud of for that. And there's a strength in that. And I can see that that's a narrative that person was brought up with, right? Is this something that I'm afraid of, that I am shamed by, or is this part of me and something to be proud of, something to incorporate into my personal narrative? And I see that with my fertility patients too, right? And Aimee can tell, there's two different ways to approach this. You can kind of, once the tumult and the challenge is over, you can own it. And it becomes a part of you, and that doesn't make it any less painful, but it becomes something that is part of woven as part of the fabric of your life, rather than this piece that you see as broken. And there's really an element of healing and wholesomeness with the world around you, with the gifts that God has given you, that are important to get through challenges in life. And certainly those who have had, family members who have gone through a challenge, who have gone through a cancer diagnosis, or they themselves have gone through a cancer diagnosis, that's not something that gets buried and put away in the past. It's something that becomes part of who they are as they grow through adulthood. It doesn't go away. And I think the more we can own that, and the more we can honor that, the better the whole family will feel about the process.
Thank you. I guess now, kind of moving into our next kind of phase of this discussion, there were some questions about stress and its impacts on fertility, and anxiety in fertility treatments, and psychiatric medication and treatment. And so I think that's important to also address and kind of dispel some of the misconceptions, or some of the things that people think are generally the rule, when in actuality, there's a lot of nuance, and there's a lot of, I think, kind of misinformation about how you're supposed to be in terms of your mindset and your mental health, how you're supposed to be in treatment, and what you're allowed to be doing in terms of, taking care of your mental health. So I think that that's something that we should really kind of tackle also, and dispel some of those misconceptions.
So I'll start with the pure medical, and then I'll pass on the mental health aspect to you. But I'll start with, we touched upon stigma a minute ago. As much as fertility and infertility has a stigma in the community, mental health has maybe as much, or if not more. And where the two meet, there's a lot of, insecurity, vulnerability, shame, secrecy, all of those wrapped in together. And so there's, to kind of just lay it out there, infertility, whatever the cause, is a stressful situation. It's stressful, it's anxiety provoking. There's a lot of uncertainty. We don't know exactly how this is going to turn out, or what it's going to take to get there. And that's normal. It's normal to be anxious. Nobody's going to be happy and excited to go through fertility treatment. I do often tell my patients, there's nobody whose plan it was to walk into my office. When I'm seeing you, this was not plan A. And nobody's happy to see me. So I recognize that, and it's important, that we can own that, and we can say, we can be upset, you can be unhappy, and your anxiety and your stress is not going to change your outcome. So it's not that if you're anxious and upset and stressed out, that somehow your infertility treatments are not going to be as successful. They're not related. Now, we know that stress has all sorts of hormonal impact, and it does, and I'm not belittling that, but this is something I like to say often, and Rachel and I were talking about this before. If stress in and of itself were a cause of infertility, or caused fertility to be diminished, the human race would cease to exist. We are a stressed kind.
Say it again.
There have been, the human race has managed to procreate during times of famine and war, displacement, and all sorts of terrible, horrible things. We've managed to figure out how to reproduce. And so you being stressed is a normal important response, and don't stress about being stressed. It's okay. We can own that. When does stress require additional treatment? Look, we've talked about it. Get the support that you need. Getting mental health and emotional support is an important piece of really any journey that involves challenges, whether that's a fertility journey, a cancer journey, a fertility after cancer journey. All of those things are stressful, and having someone who can give you that support, that objectivity, that's outside of your family, that's outside of your relationship, that's a safe place, is important. And whether that support includes medication is okay. There are so many mental health psychiatric medications that are completely safe in pregnancy. They're safe in fertility treatments. They're safe in pregnancy. They're not going to impact your outcome. And really having a healthy mom, which includes mental health, is the most important piece in terms of having a healthy pregnancy and a healthy baby. So if that mother needs antidepressants or needs anti-anxiety medication, there is no reason that she needs to suffer in order to go through her fertility treatments or to go through her pregnancy. There are so many options that are completely safe and appropriate. And so I'm just putting that out there as fact, because again, I think our most important message from this is to be proactive and to ask questions and not to make assumptions. So I have so many patients who say to me, oh, I have to go off my medications, right? I'm like, no, actually you don't. There are some medications that are not safe in pregnancy, and we work with appropriate psychiatrists who can, give us the advice of, okay, this is better than this one. And this is we'll get to the lowest dose that's safe, all of those things. It's very nuanced, but we cannot and should not make blanket assumptions about what is and is not recommended in pregnancy, because it's so individualized and there's so much more that's available than people tend to think that there is.
Yeah, the one thing I'll just add to this is that the other layer of support that one should seek out when going through fertility treatment, especially if you have an underlying anxiety disorder or any sort of mental health issue, is to not only, provide yourself with the support, the psychiatric support, and the assumption is that you're already, buttressing yourself with your mental health support, but also let people in your life know that you're now undertaking something else that's going to be stressful. You want to have others who can sort of look at you and say, I don't like the way you look, or like, you're worrying me, and I know that you're nervous, and like, let them be a guide for you. Let them be that impartial guide and be able to tell you, hey, I think you need more support now. So I always suggest to people, when you're going through any kind of stressful situation, you want someone on the outside who can like objectively look at you and say, like, I think you need to go to your doctor now. And I think that that's really important. It's something that I did for myself when I was postpartum with my kids. Like, I basically would deliver my kids, and then I would say to my husband, now remember, I might end up having postpartum depression or psychosis. I'm not going to know it. So I need you to tell me whether I'm a mess. And if I'm a mess, I will listen to you. So I think like, you always need to have those people around you that can like be those, like, I'm thinking of a word that is escaping me at the moment, but those like signs, those signals, those buoys, those things, you know what I'm talking about. Anybody?
Yes. I'm not sure exactly the word you're looking for, but I know what you mean. You kind of want them to be those people that, not call you out, because I feel like that's a little bit too harsh, but the people that, kind of call you out and say like, hey, you're really not yourself. Yep. And I think as much as like we know each other and we know ourselves and we're the experts of ourselves, sometimes we're blinded also. And I think that's, important to remember, like sometimes the people we love can see things that we don't really see. And it's important to find someone that you trust and that you're willing to listen to, and that, also, kind of won't like hold it over your head or hold it against you, to really in a compassionate and loving way say like, hey, I'm noticing this, and like, I might be wrong, but this is what I'm seeing. So I think that's really important. I think that something that both of you were saying here, and I think I kind of just want to like emphasize it in my own words here, is like telling people to relax, like don't, like, it doesn't work, right? Like we shouldn't be telling like, oh, you're going through fertility treatments, just relax. Like literally nobody in the history of the world, right? We know that meme, like when you're telling someone to calm down, like no one in the history of the world has ever calmed down. Like it just doesn't work. And I think that we even need to kind of like normalize and say like it's okay, and actually part of the process to feel anxious and stressed when you're going through something like fertility treatments, especially post-cancer treatments, where you really don't know, what your outcomes are going to be, and there is an extra level of complication and risk there. So I think that telling people they should be calm and relaxed or go on vacation, or even giving options of, hey, if the fertility treatments don't work, you can just adopt. We really have to be very conscious not to make those suggestions like ever. And I think in general, the rule really is like, don't make suggestions. Don't be like, oh, did you ever try, whatever water, or like, did you try not eating this or doing this, or
herbs.
Right. I think it's important that people realize that people going through fertility stuff, like, most probably know what's out there and what they should or shouldn't do. And they don't need those suggestions. They just need support, right? So they don't need you to tell them to, oh, I heard that you should like cut out gluten or whatever. Like, no, you can just say like, hey, if there's any way I can be helpful, I want to be helpful. And I just hope that I can be supportive. And if you want me to help you find support, I know there's wonderful organizations like Small Wonders, or I Was Supposed to Have a Baby, or I know this amazing doctor at Extend, or whatever it is that they say, offer what they know, if you want it. And again, we also, if you're the person that wants to offer, make sure, always ask before, like, I want to give suggestions, or I want to help, like, are you open to that? And let them say no. Let them have that boundary of like, I don't want to have you involved in this, or I'm not ready for suggestions right now. And even if, this has come up in my work with my clients, where, I've had either family members or friends say like, oh, I'm so worried because I feel like my friend is like at the worst clinic. Like, I know this is not a good doctor for her. And I'm like, you literally can't say anything, like it's not your business to start like, going on medicalgrades.com and like sharing the reviews. Like, it's not your business, and I think that's important too, to just kind of be very sensitive with like what you decide to criticize or share your thoughts on. And that's kind of what we wanted to end with here, that piece of the conversation. Like, how should we be supportive? What are the perspectives that we should have on our role in, our family members' struggle or our friends' struggle? Like, how should we behave with them? What can we say or not say to be helpful? And then even for you, if you are the individual that's going through it, how can you set boundaries and communicate with your family what you need?
So I think that, we got a question here, which spurred this, part of the discussion, which was, at what point do you tell a couple to look into adoption? If they've been trying for 5 years with no success, is it time to give up? And so, at what point does it become your business is my question. That is really the question. And I think, Dr. Maslow will talk about it from the medical standpoint in terms of having these discussions with patients about when it is time to potentially move on and try something else. That's a medical conversation. What this question, and Dr. Maslow, I want you to get to that, but I would just want to address the psychological piece first. So it is never appropriate to tell someone else what to do, period. Like infertility, in life, we can't tell other people what to do. What we can do is we can support them in whatever choices they are making. What we can also do is say, it's really, I see you struggling for 5 years, and it really hurts me because I see how much you want to have a child, and I see how this is not working, and my heart breaks for you. That you can say, but you can't end that with, so why don't you go look into adoption? It's not your place to make those kinds of decisions for them. And just sort of a side note about adoption, which I think we talked about a little bit, like adoption, like often the concept is like, oh, well, why don't you look into adoption? Or why don't you look into surrogacy? So adoption and surrogacy are not things that you just do. number one, they take, upwards of 2, 3, 4, 5 years. They're exorbitantly expensive. They have, hundreds and hundreds of hours of this and that, and asking different questions in different agencies. I could go on and on and on. So there's no such thing as sort of just do adoption or just do surrogacy. It's a lot of work. So it's never should be offered as an option, but also it's not your place to offer that option. It's your place as the person who's supporting someone who's going through this to be there for them in their struggles. How they choose to pursue their medical treatment or not pursue their medical treatment is between them and their doctor.
I would totally agree with everything Dr. Barron just said. We don't live in an age where there's like stockpiles of babies that are being given away for adoption. It's just not the reality. And oftentimes actually pursuing fertility treatment is easier than adopting many times. So that notion is just not really based in reality. And it's an expression of, I think, what you said earlier, that people feel your friend, your family member's pain, and you want to ease their pain in some way. And if in your mind this feels like a way to ease pain, then that's a suggestion that comes. But I think if you step back from making those suggestions, like we just said, you can be a much more effective and supportive support person. From the medical standpoint, the vast majority of fertility doctors are not trying to swindle their patients and trying to have their patients do treatment after treatment after treatment. That's going to be futile. That's just not the way medicine is practiced. It's generally doctors, especially in my field, are really good people who want the best for their patients. And we recognize that treatment is not easy. It's not easy physically. It's not easy emotionally. It's not easy financially. And so I can only speak for myself. I don't necessarily know the private conversations that my colleagues are having with their patients, but I will say that, with every treatment decision that's made, I have a conversation with my patients and I say, look, these are the options that are available to us. These are what I think the costs might be, both emotional costs, physical costs, financial costs. These are what I think might be the benefits. These are what I think might be the chances of success. Here's where I think we should start. Here's what I think we should do. If that's not successful, we're going to try this. If that's not successful, we're going to try this. Here's where I think we might need to step it up and maybe that we do something even more aggressive. And if we get close to the end of the line, I usually start telling people, okay, here's where, I think we should try this one more time or 2 more times. And if that's not successful, let's talk about what our other options might be. Let's talk about when is it going to be appropriate to say, you know what, I think it's time that we stop treatment, or let's take a break from treatment. Thank God, really thank God, we live in a time where the vast majority of fertility treatment is successful in some way, shape, or form, but it's not 100%. There's going to be those couples whose fertility dreams don't get realized. We know that, that. Thank God it's still a very small minority. But we have to be honest and realistic. And, I try to be as realistic as I can with my patients and say, I very rarely tell people that I think there is 0% chance, because I'm humble enough to know that, God works in very mysterious ways and there are chances, but it may not be worth doing X, Y, Z and spending this amount of money for a less than 1% chance. There might be others who say that it is worth it. And it's not really my place to judge whether, how you spend your money or your time or your emotional investment. But it's important to be realistic and set boundaries and have those open conversations. So if you're in a circumstance where you feel like you have a friend or a family member who's in a fertility journey, who's not having those conversations where they're physicians, the proper suggestion might be like, maybe it's time for a second opinion. And, I welcome second opinions. I welcome my patients getting second opinions elsewhere. I welcome bringing in second opinions because, a fertility journey, can be a long process, right? You start at point A and you try something, and if that doesn't work, you try the next thing. And sometimes people can get lost in that journey, and having a fresh set of eyes might try something new. Sometimes there's a mishaneh makom, mishaneh mazal. You try a different lab, a different doctor, there are a lot of different factors here. And so if you feel that your loved one is not having the proper conversations, then maybe the right suggestion is to just get an opinion. You can always go back to the doctor you started with if you just went for a consultation somewhere else, and get a fresh set of eyes. I think that's always helpful. But recognize that really the vast majority, all, if not, 99.9% of doctors are having these frank conversations with their patients. And so the patients can make decisions about what makes sense for them and what makes sense for where they want to invest their time, their emotional capital, and their financial capital.
That kind of ties everything together in a really beautiful way. And I think for me, what I was hearing kind of, again, the theme of the night for me was really that there are conversations that need to be taking place, that we should never be assuming things. We should never, even say well, I heard once that X, Y, Z in this case. We should always kind of view ourselves as individuals and really view yourself even as a special case that you do need consultation. And you should never assume because you heard that someone's sister had the same situation or someone's brother had the same situation that the same thing is going to apply to you, or they went to this doctor and they were successful, so you're going to be. And like Dr. Maslow was saying, if it's not working, you can always say okay, I heard they're the best, but maybe they're not the best for me, and I can go and get a second opinion somewhere else. And so I think that we need to continue having conversations with professionals, with the experts, with the people that know, continue having conversations with our families about what we need from them and what we want for them, continue being honest with ourselves and with our kids. If our kids are the ones that are going through these things, and understanding that knowledge is really empowering, and knowledge often takes away fear, right? It takes away those questions of am I normal? Is this normal? I think that's really important. Not assuming also that, I like the point that Rabbi Weitzman said about, the whole shidduchim system, and thinking either we have to completely withhold something or we have to tell right away, or it is not black and white. Nothing in life is black and white. These are complex issues. They have complex answers, but we also have people to address them, right? And some of those people are here tonight, and there are, so many resources out there. And I think that tonight is just highlighting how many wonderful people there are that are available to help you and guide you through this journey. So thank you.
Wow, Rachel, thank you for summing that up so beautifully. And Dr. Maslow, Dr. Barron, thank you. And Rabbi Weitzman, who is on Israel time, we thank him so much for his contribution. I really can't tell you how much I appreciate this. And together with Small Wonders, that we put this evening together to really encourage conversation and to leave us with a message that, Dr. Barron, you said to me originally, there are no guarantees, but there are options. And that's what stuck with me, because you guys are sharing that message, and that's a beautiful thing to spread, because together you guys are working on erasing the stigma, on improving communication and improving the chances. So I thank you guys so much for your time and for sharing, and your expertise and your care. Your perspective is greatly appreciated.
Thank you.
Thank you so much for
everyone
having
for
us.
joining us. And I'll wish you all a good night. Thank you.